So the session today, I would like to keep it simple. Can someone explain this to all of us? Have a volunteer, then
I'll volunteer if nobody else wants to.
It's okay. Please go ahead.
Well, it's a basic anatomical diagram of the kidneys and urinary system. Kidneys at the top towards the, if I recall correctly, towards the back of the body. And basically the kidneys filter all the junk and toxins out of our body and excrete them in the form of urine, passing that urine down the ureter into the bladder, and then we urinate it out. And that's in a functional with people who have functional kidneys, that's how you get all the nasty stuff out. And for most of us, our kidneys have stopped being able to do that, and so we're giving them a boost with dialysis. We're using artificial means to supplement what kidney function we have left.
Thank you, Ashton. So just a disclaimer, I am doing this from home, so my children may pop in as they see fit. So so the next slide, I think you explained it very well. Kidneys, the usual size is 10 to 12 centimeter, and really it's attached to back of the body wall. So anatomically, there's front of the belly or the front of the abdominal wall, and then there's a back. So they are basically kind of attached to the back, to the front of the back wall. So they are retroperitoneal, which means like people who do peritoneal dialysis. So whenever you fill the peritoneum with the fluid, it doesn't actually even touch the kidney directly. So it's kind of behind the peritoneum. Ureter is the tube that connects the kidney to the bladder, and then bladder is just a storehouse for the kidney, so we don't pee all the time. The basic anatomy of the kidney. So this is the renal artery, which brings blood inside the kidney. See that, the very pink artery, and this is the renal vein that takes the blood out of the kidney. So again, I think we saw the ureter here. This is the renal pelvis, so the area that's like kind of the funnel that gets all the urine, collects all the urine. So this is your urine collection agency, and these are, you can see some calyces where a lot of action happens. So the blood comes in, it gets to small arteries, and this is the filter, if you can imagine. And so blood goes through these filter, and the urine is collected into here, and the blood goes back. If I give you a perspective, normal 2 kidneys in one day, in 24 hours, filters anywhere between 150 to 180 liters of blood. So say 180 liters, how many gallons it will be? Anybody wants to make like a guess? I'm just cheating. Roughly 50 gallons. So your normal kidneys, each kidney kind of in a day filter 20 to 25 gallons of the blood in both kidneys, roughly 50 gallons of the blood. So, but you only make less than half a gallon of urine. So all this blood is kind of filtered through the kidneys so many times that it really cleanses through the process. And the urine, so a lot of people ask me a question that, I'm making a lot of urine. Why are my kidneys not functioning? So the difference is like the clearance, instead of 50 gallons per day, they only kind of rinse maybe 4 or 5 gallons a day. So the urine is not very smart. The urine with the normal kidney is smart urine. The urine in the kidney with low function is not very smart, because not a lot of processing has happened. So that's one concept to understand, that kidneys really filter the blood. You have 5 liters of the blood, and that gets filtered so many times in 24 hours. So this is called nephron. Nephron is really that functional unit of the kidney, and this is so small that each kidney, the small kidney, has 1 million of these nephrons. So really, the at the end, as I mentioned, that all the blood that it the blood vessels keep getting itself branched into smaller and smaller branches, and blood goes in this capsule and comes out from here. So this is where the urine, which is, I would call, the fluid, and it gets filtered, processed, go down and up. So there are a lot of things that happen to that filtrate through this process, and eventually it goes to the bladder. So you can see that there are some loops, things kind of hairpin that go dips down in the kidney and then comes back up, and how body kind of handles. So if you live in a desert, you only make, say, half a liter or 3 quarts of urine. But if you are like kind of, you're not in desert and you drink a lot of water, you just pee out everything. So this is where kidney kind of balances, and a lot of functioning of this concentration and dilution happens in this machinery. So it also has very complex vasculature. Now this is quite a complex diagram. So the big picture is, I showed you, this is the same nephron we saw in the past in the previous slide. And this is the main thing is, if you see, this is one nephron, this part of the snake, and this is the other nephron, right? So what happens that when blood comes here, if you track this red one, it goes through this filter, and then when it comes around, not only that urine is flowing through these tubes, the same blood vessels are around those tubules as well to do a lot of reabsorption and some other functions as well. So they do a pretty complex job day to day to maintain the balance. And one of the biggest function of the kidney is to maintain the balance, homeostasis, the balance of salt and water, the balance for the blood pressure, the balance for the all these electrolytes, the phosphorus we discussed, potassium, sodium, calcium. So there are a lot of different things. This is your balancing organ. So questions. What do the kidneys do? I think they've used this mnemonic wave. Number one is waste. So as I mentioned that, the waste is really the metabolic waste. Body has metabolism, cells are functioning. Every living thing has waste. So kidneys are part of the waste management. Your gut is the other part of waste management. So sometimes when the GFR declines, then body actually switches some of the kidney function to the gut for some of the clearance of salt, like fluid and salt and electrolytes. But of course, gut is not designed to do all that at job. So it doesn't do all this catch-up function. So one is cleaning of the waste. Other is the maintenance of acid and base. So a lot of patients who, when towards the later stages of kidney disease, they need soda bicarbonate pills because their acid base level is disturbed. So they don't have enough alkali in their body. So you give them exogenous alkali or bicarbonate by mouth. So just to give you perspective, baking soda is what that bicarbonate thing is. So really kidneys maintain your waste balance, your acid base balance, then the volume status. So that is where salt and water, anytime you combine salt and water, that's your volume status. Because so if in physiology books, if somebody who's 72 kilos, 42 liters of that 72 kilo person is water. And really kidneys maintain that water, salt, and volume in really tight balance. So if you are dehydrated, then it helps you to conserve the future losses of water and salt. And if you're overhydrated and if the organs are kind of building up some fluid, like lungs have some fluid, the legs have edema, then kidneys get rid of some of this fluid. So question to everybody who's on dialysis, I should think about it. Every time you go to dialysis, we remove 3 to 4 kilogram, which is 3 to 4 liters of this volume out of your body, right? So depending upon what the gains are, some patients need more volume removal, others need less. Anybody. So this is an important job of the kidney to maintain the volume, and if it is not there, then patients gain fluid weight in between the dialysis sessions, and every time they come back, we have to remove all this volume with the machine, whether this is hemo machine or PD machine, or sometimes we give water pills to augment the volume removal by the kidneys, although that volume removal may just be like not very smart urine, but at least this takes care of some of the fluid out of the body. And another function is the endocrine function. So three or four, like three major, some others as well. So one is the erythropoietin. So everybody's familiar with Procrit or RNS or Mircera, all those shots we have to give you exogenously in the skin or in the dialysis machine to maintain your hemoglobin level, is because kidneys are not there to give you that supply. So we have to supplement that. And I remember, I have not seen very, since I've been practicing nephrology, we have RNS available in USA. But I have seen some patients who RNS was so expensive that they just could not afford. And do you speak with Dr. Carroll or somebody who has seen patients in 1980s and 90s and 70s when this drug was not available? Patients were always anemic, always, and because of that, they were getting a lot of blood transfusions, and they got I think their face and their complexion changed, and part of the reason was, lack of erythropoietin and lack of this body's natural ability to make blood, and they were getting exogenous blood. The other hormone, which is very important, is renin, and that controls the blood pressure. So anytime patients' blood pressure can cause kidney disease, and kidney disease can cause high blood pressure. So if anybody remembered the days before dialysis was started, the blood pressure was always kind of a part of this whole puzzle. And then vitamin D, calcium, phosphorus, and basically your bone health. So kidney play an important role in your bone health. So it actually sends something, it's like some signals in the body to suck more vitamin D out of the gut. And in the absence of that, the body actually relies upon vitamin D and calcium from the bones, which makes bones quite weak. So it's actually important to, so I'm sorry, I think she just kind of ran down. So she's going to be with me until she's taken back. So this is Mina. Mina, say hi. So we'll go to the next section. Next section is how common is the chronic kidney disease? So if you 15% of the population, so this is a very large number in USA, and I think I think this percentage is quite high, and part of the reason this is high because we can detect it, right? So there are countries who do not do a lot of screening, so it's actually they report it to be low, but it's not actually low. So patients who are on dialysis, this is actually, there are do we have, Lynn, do you know the number of patients on dialysis? Oh, actually this is there. So 746,000 patients who are on dialysis. And this for some reason, this disease affects patients from African American and Hispanic population a little bit on the disproportion. So their numbers are high. One thing which is very important that, thank you. So is that the cost, the dollars we spent on the kidney disease are very, very high. So, but the outcomes are not as good as you would want them to be. So if I go back, I remember back in 1990s, the outcomes of the kidney and cancer, they were equivalent. And this was written, like, I think a lot of articles about it. And this was, luckily in the last 10 years, this has changed. You know, finally the outcomes on the kidney, the data which we saw between 2005 and 2015, finally we started to make some headway in improving the outcomes, which is mortality benefit is now there. So another common, statistic to remember is that what is the major cause of kidney disease? This is pre-dialysis in USA. So two things, worldwide, although I always describe is like, just think about if there is a disease that starts outside of the kidney, or if there is a disease that starts inside of the kidney, right? So really the diabetes and high blood pressure are the things that start outside of the kidney, and they are the biggest player in the town. You can see diabetes 40% and blood pressure like 28%. So the primary kidney diseases like cystic diseases or glomerulonephritis is only 7.9 or maybe like 10%. So things like IgA nephropathy, I don't know if people are familiar with, that's a common glomerulonephritis. So, and then, there are some unknown causes too. But if we cover diabetes and high blood pressure, we cover the major cause of chronic kidney disease. So if the next question is, go ahead.
Do we have any idea what COVID-19 is going to do to these numbers? Just I've seen a lot of reporting that one of the after effects of COVID-19 seems to be kidney failure.
Yes, that is true. I think we actually, Dr. Ghiramani, who's our division chief, he recently published a meta-analysis about all the studies published today to see what kind of kidney. So right now, because this is all very recent, so COVID is causing kidney problem by two mechanisms. One is, so imagine like, so 10%, so 10 to 20%, depending upon which center you look at, of the hospitalized patient are in the ICU, and then another 20% of those patients have some kidney involvement. So a fourth of the patient, say a 1/5 of the patient are in ICU, and a fourth of those, 1/5 to 1/4 of them has some kidney involvement. Two primary trends which we have noted. One is because COVID has caused sepsis, and sepsis has caused low blood pressure, and it's really the body's kind of functional shutdown leads to kidney shutdown, which is the same reason for majority of the kidney failure. The second category is like COVID directly or indirectly causing problems inside the kidney, whether this is glomerulonephritis. See that actually today my colleagues presented a case. We are writing that case report. COVID patient was perfectly okay, not sick, but kidney failure. Or that microthrombi, which you are reading, like those small, tiny blood clots. So you saw that how vascular, which means like kidney has a very high blood circulation and small, tiny blood vessels. So those microthrombi or microclots are causing this. Now, long term, we don't know. So, but anybody who has the regular kind of tubular necrosis, they are more likely to have early recovery, chances to come off of dialysis. But with somebody who is getting problem within the kidney, like glomerulonephritis or those microthrombi, they have the bad prognosis long term and in the near future. So let me see, there were some chat questions as well. I'm sorry, I didn't see that. Okay, so this was just about that echo thing. Any other question? Did I answer your question, Ashton? So the next, let me make it a little bit big so I can see everybody, is the so we discussed like diabetes and high blood pressure are the two major causes. The question is, how can you prevent it and how can you control it? So I think screening is important. That really what helps is early detection and trying to remove the underlying etiology, whether this is an obstruction or some dietary supplements or some medication like NSAIDs, which are Aleve, ibuprofen, Motrin. If some patients are taking too much of it, really you need to detect early and prevent. And that actually can give patients several years without dialysis. So if somebody is at stage 4 and need dialysis in 10 years versus other person needing in 4 years, there's a huge difference. And that's where I think healthy lifestyle, control of blood pressure, all those things come in play. Smokers, quit smoking, avoid toxins. Really the main thing in my mind is control your high blood pressure, control the diabetes. If somebody is obese or overweight, they need to lose their weight, because that actually also helps kidney to recover. And really, if somebody is dehydrated and they take some medication, they have other like heart and lung conditions, they need to address their dehydration sooner before there's a lot of damage done to the kidney. So early warning signs. I see that this is like a slide which probably those stars, so things kind of pop in. So anybody remembers like any early warning signs, if like how this was detected in your case long time ago before the Philip, you want to say something?
Yeah, I got you. Go ahead, I'm sorry.
No problem. Just the way I presented was massive edema, pitting edema in my legs, and I didn't have pitting edema in my abdomen, but I had a swollen abdomen. But I think by the time I was diagnosed at the Children's Hospital, I had 40 pounds of water in my body or something like that.
Wow.
Yeah, they were amazed that I didn't go into congestive heart failure. But yeah, that was the symptom that I had was pitting edema.
Mm-hmm. Anybody else remember their symptom?
Yeah, I'm going to start back when I was a kid. I didn't find out till I was 7 years old that I only had one kidney. I was born with only one kidney. And I really didn't have a problem with it until I was in my late 20s. And I got put on some medication to help control the creatinine. And but then I'd say in 2010, I got a urinary tract infection. And so I went to my urologist and then check it out, and here found that I had a tumor in my bladder, which was very cancerous. It's like one of the worst you can get. And it was eating through the wall of my bladder. And they just caught it in time that it did not spread throughout the rest of my abdomen. And so that's how I found out. I mean, the tumor was taken out. It's gone. I haven't had a recurrence or anything, which is great. But I just want to say one thing when the last thing was said about smoking, because my urologist asked me if I have drank or smoked or anything. I said, no, never in my life, except like a beer or two here and there throughout my years, But I never drank like heavy or anything like that. And he said the kind of cancer I had was for the older people get it. He said, I've never had a person my age. I was like 42 at the time. And he said, never had anybody my age get that. And I said, well, what would cause it? He said, well, if you were a smoker, you could have got it from smoking. And I said, well, my parents smoked a lot. heavy when I was a kid. And he goes, that's probably how it came about. And so it was like secondhand smoke gave me the cancer. And I was like, okay, well, but that's how I got diagnosed.
Wow, that's a very rare kind of story. I think your urologist is right. So the kind of cancer you have, we really see it's a function of time. It takes time and some other insults, which is smoking, kind of second and third insult. So maybe you were exposed to the second-hand smoke so earlier on that your time started when you were a child, not like when you started smoking, or somebody will start smoke themselves. So it's really a function of time. Anybody else want to share as if they got any early warning sign of the chronic kidney disease? Because what Phil shared is not early. It's quite late. That much swelling is quite late, and that is the unfortunate truth, that it does not give you a lot of early warning signs.
Husband found his during a radiology residency. He was doing ultrasounds with the other students, and they discovered his cysts on his kidneys. So he got early warning just through that sort of luck or unluck, as you might call it.
Yeah, so no incidental findings. So I assume this was a polycystic kidney disease.
Yeah, polycystic kidney
because
disease.
At such a younger age, if somebody needs, so that makes sense.
Yeah,
so yes,
no symptoms. He just saw the cysts.
So what happens in those patients sometimes come to us when by the time the horse is already out of the barn. So because once they hit their 40s, their function starts to decline on a slippery slope. But even the early detection by incidental finding actually sometimes helps you to pay more attention to the high blood pressure and any complication that can happen in the cyst. So you want to assess and treat those really to prevent the future complication, but delay the onset of dialysis. So instead of starting at age 40, it may be delayed by age 45. And sometimes, those 5 to 10 extra years give you a lot of bang for the buck. Anybody else wants to share their story?
So for me, it was, I was feeling tired and run down, but the most notable thing, I think, was, and when I talked to you about this, you said it was almost certainly uremia, was I started smelling chemicals on my breath. Like almost an ammonia, an ammonia smell. And I remember really clearly, I was walking through the Charlotte airport, getting ready to come home, and this was before I started dialysis. And I think I just started meeting with you, and we were talking about this as a possibility, and just realizing, what is that terrible smell? And then realizing, oh my God, that's my breath. And then after talking to you, realizing that it was probably because some of my blood chemistry was badly off. But that was when I really finally noticed it. It said, okay, that's really like a clear, and I don't know whether it's because I'm diabetic, and one of the things that you're always kind of paying attention to is, you worry about ketones and things like that. But it was very startling to have that chemical smell. And I don't know whether anybody else has experienced that. It might just be me being a weirdo again. But it was pretty unpleasant. And now I'm noticing that I can always tell if I've been a little bit sloppy with my calcitrol dose, even though it's just a tiny dose in micrograms. If I miss it for a day, I can tell. It just kind of, oh yeah, here we go again.
Oh, that's a very sensitive sense of observation and picking up the symptoms. So coming back before any if anybody else wants to say something, then I will share my experience of seeing patients as okay, I assume it looks like that I have to go. So early warning signs and late warning signs. Unfortunately, the progressive or advanced kidney disease is a painless condition. And by the time you start to see the warning signs, it's a little late. Two common themes. One is the edema, which Phil mentioned, and the other is extreme fatigue and tiredness. So that will cover 70-80% of the most common presenting symptom of advanced kidney disease. So why are we talking about early warning? So really, if somebody who, now you have to kind of consider this as a population. If you are the director of population health and you have 1,000 people in you're managing 1,000 patients. So you will, if you have 100 of those who have diabetes and high blood pressure, and you know that this is the population who is at the highest risk of developing kidney disease, then you as the director of that program will check their blood creatinine and their urine protein once a year at least to make sure that you are doing some screening for the kidney, and also to make sure that their blood pressure and blood sugars are so well controlled that even if they have some kidney disease, it does not progress rapidly. So that's the I think something which is important when we see patients. When I see patients in the kidney clinic, and maybe when you will speak with the mentors as the mentees, one of the thing is they may have family members so who may sometimes follow some similar pathway, so at least they can educate the family members. So it's a good point to let people know. So alrighty, so this is something which I know Dr. Carroll talks about a lot. So this is the how the serum creatinine as a single test can deceive you from understanding the true kind of function, because the serum creatinine is just one marker, but the GFR, which is glomerular filtration rate, this is kind of a combination of your age, your weight, and gender and race. So a serum creatinine of 1.3 may not be the same in 24 years old Black gentleman with his GFR is more than 60, or just imagine this as a percent function in the kidney, and 63 years old white man, the GFR is 59, less than 60. And if this is a 59 years old white woman who is same creatinine of 1.3 equals 45% function or 45 GFR. So this person is not, so this person is stage 3 early, this person is stage 3 advanced kidney disease. So you can see that it's important that serum creatinine, if this is abnormal, and usually the good thing is labs these days are good at reporting the GFR along with creatinine, just to give you like a good assessment as where this person's kidney function is as of today. This is a very old model of, kind of, I have seen this. So really it's kind of goes from when somebody has high risk, it causes damage, decreased GFR and kidney failure. And then once the kidney failure sets in, there are some complications. So how to slow the progression of kidney disease? I think I discussed this. To me, if you do your ABCDE right, it's not on the screen, but remember A for aspirin if somebody has heart disease, B for blood pressure, C for cholesterol, D for diabetes, and E for exercise. So those are like really your main slow the progression of kidney disease. I'm sure stopping smoking helps. Food, eating habits, they also help. Low sodium, protein restriction. If somebody is pre-dialysis and advanced kidney disease, once you're on dialysis, you don't need that much protein restriction. So that's why this subject is always tricky. Patient asks questions like, Dr. Farooq, you told me few months ago, don't eat too much protein. Why are you asking me to eat more, especially if somebody's on PD? So I think the paradigm has shifted. Now you need more protein. So again, blood pressure and diabetes control are important.
Farooq, I was wondering, I know in the news this week, there was an article that I noticed that some institutions are trying to work against that racial bias in GFR scores, that it was really based on an erroneous study that seems to attribute higher muscle mass in African Americans when that's really not the case. And so some institutions are trying to do away with that racial distinction. Do you know if that's moving ahead in our area?
It's so Boston, I think some programs in Boston have done that. So, it is, yes, the MDRD study, I think if you go back, so this was the MDRD study, and I think people have questioned, this was done a long time ago as well, and there have been some secondary, derivatives from some of these equations as well. So in the nephrology community, people are talking about it, and I think they have, anytime you present like a new concept or you like to change the paradigm, there are some discomfort into this clinical, how we have understood a disease. But the knowledge, this is about science. Science changes, and COVID has just taught us that how quickly science changes, right? Because you made a discovery today, but when you did like large scale testing, that discovery was not as robust as in the small scale trial, like what happened to hydroxychloroquine and what's happening to some of those other drugs. So yes, some institutions are going, because what has happened so the reason we are able to do that, since the MDRD study is done, there are new equations. One equation is called CKD-EPI. So they actually have, like, those mathematical formulae are now more advanced. So if we start to use those, because we use those formula all the time in the research settings, so we can go away from, I always kind of, I never liked it to have it. Whenever I see this EGFR, if this is, I think it's okay to attribute this to gender, right? Because of the natural difference in the composition of the body water. But I think more so with the racial kind of, having two separate EGFRs, I'm actually fine with as a nephrologist, as long as we use the modern equation, which is the CKD-EPI, which actually we tested. We actually beated that equation. Dr. Jane and I, we did a trial. Actually, we published some of the data, and we look at the creatinine clearance of immediately after the kidney transplant, and we measured the timed urine every 12 hours, and then we compared the regular EGFR equation, the CKD-EPI, the actual 24-hour urine measurement. So just to scientific experiment, and some of the older equations, they don't perform very well, but the newer equations are actually quite robust. So as long as we use the CKD-EPI, which means like the labs now have to adopt this widespread nationwide, I think change is coming. It just started. It will actually, make our life a little bit easier. And I think I like this concept, because there are, as I say, there are scientific basis behind this concept. If those institutions are doing, they're doing it for a good scientific reason, not just for political climate reason, right? So it's a good step, I think, at the right time, which will lead us. Now people will do more studies like what I did in that small population in the transplant. Now they will do this in the larger population, maybe a population-based study. So this concept will be, I'm sure, is ready for revision again. So thank you for this question. All righty. So complications of chronic kidney disease. Anybody else wants to say anything before I go to the next? Because I know we are just discussing some of those new ideas which are around the globe. So what are the complications of the chronic kidney disease. So really imagine if the GFR is going down, so your percent function in the kidney is declining. So of course, all of this has some impact on the body itself. You just cannot, kidneys are not going at 65 miles per hour they used to. They are only going 20 or 25 miles per hour. So they're not going to carry all that, the baggage, and then they will not do all that clearance. So the complications happen because the waste is accumulated. The edema or the volume status is kind of, disturbed. The acid base, potassium high and sometimes low as well, calcium phosphorus works together, and those anemia or endocrine abnormalities. Basically, as I explained, whatever the good things kidneys do on a good day now, because they are either less doing or not doing, then you see complications around those functions. So if waste, which is urea, it builds up, it can cause neurological problems, lung problem, GI disturbances, taste disturbances, nausea, vomiting, itching, sexual dysfunction, and bleeding, because the platelets are there, but they're not very functional, okay? So again, I think so for the specific to uremia is in a stepwise fashion. Appetite and sleep are the first one, and GI, and then sexual disturbance and skin, and neurological is towards the end, when patients are so sleepy that they feel comatose or they start forgetting things. So that's the uremia. Okay, so the next slide is question. Can you name some of the neurological effects of urea? Wow. Actually, uremia, it says. I'm sorry, I have to move it. I think I kind of touch base. Anybody wants to take a shot? What happens to the brain?
I don't know the exact physiological changes, but I know for me, there was a period when I was doing PD when I was highly uremic, and my thinking was extremely foggy, and I had a lot of trouble focusing and on things that I needed to do. So that was what happened to me.
Spot on. So fog is the perfect description. And I really want, I really like when patients tell me something, because their words are so descriptive and in such a beautiful way that whenever I use this word a lot in front of other patients, they quickly latch onto it. If I keep using the scientific words in the books, not everybody understands that quickly, but anytime I use the word fog, it's very self-explanatory. Thank you for using that. Anybody else wants to say something?
Oh, I see said memory loss.
Yes, memory loss is one. Absolutely, yes. So memory loss and fog. So unable to process the information and difficulty remembering. So let's go to the next slide. So we talk about the confusion. We talk about the decreased consciousness. So these are the and coma can happen as well. So it kind of imagine that it affects most of the neurological. So it actually makes the nerve conduction slow. So it slow in some areas, fast in other areas. So either there is loss of sensation, altered taste, the legs are not happy because of the electrolyte issues. Patients can get twitching, muscles are connected to the nerves as well, and then dialysis or the kidney related fog, as you just mentioned. All righty, next question. Please remind, I know Ashton mentioned about some of the taste changes, but any other GI side effects of uremia?
Vomiting, nausea.
Yep. Good. Spot on. Appetite, nausea, vomiting, malnutrition. And I have seen patients, they start to lose their weight and they develop like this bitemporal wasting, like, their they develop a lot of muscle wasting on the sides of the forehead. So you can visibly see that. And it's just malnutrition because body's metabolism changes. And this means like you need to replace the kidney function either by dialysis or transplant.
So I have a question.
Yes, please.
Could it cause a person to say every time you take medication or you eat or something and it makes you sick after you eat?
I'm sorry, I missed the last word. So the question is that it makes patients, what happens every time you eat, that it makes you feel full?
Yeah, I'm having trouble. Well, I've had trouble for a while with every time I'd eat something after like a meal or something, I'd feel sick. And that's just about all the time. And I was treated for a stomach infection, and it went away after antibiotics, but it has come back since. And it just seemed like after every time I take medication or eat or get something on my stomach, it wants to come back up.
Yeah. So usually, you know, the context which we were talking is like, you know, uremia, kidney is not functioning, and then somebody's not on dialysis, they get this. What you are describing is while on kidney dialysis. So, you know, GI upset, stomach upset, or acid reflux, all of those conditions are really exacerbated even when patients are on dialysis. So maybe any pre-existing condition in the stomach is actually really magnified because of having just kidney failure. So you need to take, that's why a lot of my patients, they take stomach medication, like most of them, they just take it because this prevents some of those changes. So maybe when you speak with your physician, they can prescribe you some acid lowering medication for your stomach. That sometimes helped.
Yeah, I do take something.
Okay, you already take
take
those.
like a Prilosec pill.
Yes. Yeah, that's what I use in a lot of my patients. So there may be some other causes. If this is not helping, then I ask my patients to see a stomach specialist, a gastroenterologist, because what if they need an endoscopy or something? So that you may discuss this with your physician as what next to do for that. Okay. What happens on the heart and lungs? So patients develop sometimes inflammation around the heart lining, which can cause chest pain. Again, blood pressure could be high and low. They develop irregular heartbeat, which in fact can cause high risk of stroke. And if the fluid is built up, this goes actually in the lungs and can make breathing very difficult, and cardiac arrest or sudden heart death has been, you know, reported in patients who have uremia or their kidneys are not functioning and usually it's related to electrolyte abnormalities. Those electrolyte causes the rhythm problem in the heart. So how do we manage this uremia? Really, we need to do renal replacement therapy, which means like you have to replace the function of the kidney, whether this is dialysis, hemo or PD, or kidney transplant. Some of the complications like acid base, I think we discussed, and I touched base. Basically, usual problem is there is more acid or less alkali, so you treat with giving the alkali back, which is the sodium bicarbonate supplements. And once the patients are on dialysis, the fluid which we run around in the dialysis machine, that either has bicarbonate or lactate with next stage. So just to replace some of that, you know, losses or lower levels. So this is kind of the exogenous replacement. Alrighty, this is a common question, and I'm sure all of you know the answer to this. When your dietitian on the dialysis speaks with you, what are the electrolytes they always talk to patients? So Aisha, when Diane rounds, she always talks about some binders. So what is the electrolyte related to that?
Phosphorus.
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 Okay.
And then we ask patients to watch bananas and oranges. So what is that
Potassium.
electrolyte?
Potassium,
Potassium. Here we go. So I think they have three electrolytes: calcium, potassium, phosphorus.
phosphorus, yeah.
So this is like um, that. This is something which everybody kind of has this issue. Some patients have to a lower level. Some patients to have this for high level. Potassium, I think we can still manage easily. Phosphorus is probably the most stubborn one, right? What has been your experience? Phil wants to say something.
I actually haven't had that much of an issue with my phosphate levels.
Uh-huh.
I mean, I know last time we had rounds that mines had come back down into range.
Mm-hmm.
I think I slipped up maybe the month before,
Mm-hmm.
but for most parts, I've been able to keep the phosphate at a level that is comfortable for me and for you.
I think dietitian is the person you need to make sure that
Well,
they're
yeah.
also comfortable.
Well, yeah, Diane as well. Yes, of
Yeah.
course.
So,
But
no, you're right. Anybody else wants to add something? You share your story, share your experience, because I think we all learn from each other. So again, the most stubborn one is the phosphorus. The others, I think we have better luck in management as well. All righty. So what happens if these electrolytes are high and low? So high potassium. Oh, my daughter just opened the door. I'm sorry. I don't think. Yeah. So I'll tell her mom that she has to pick up.
Mama,
Mm-hmm.
Mama,
Yep.
Mama,
She actually opened. This was the door was kind of partially locked, but she's able to open. So, so potassium is the most common problem, and then muscle weakness and heart are the two major side effects. And this can be fatal. This can be very, very. It could be bad. It could be really bad. So, how to manage this? Do you guys? I mean, anybody wants to maybe educate? Anybody wants to experience? They share how to manage the potassium.
I take a furosemide. I take 2 of them a day.
Mm-hmm. That helps certainly.
Yeah.
I mean, managing for me, I mean, I haven't produced urine in a long time. So honestly, the best way for managing potassium is just avoid it.
I think that's the most important message is that, both for potassium and phosphorus is like, if this is a problem, you need to watch the intake. That is the main, this is how you can control. Like you need to go to restrictive diet. Patients on hemo, they have to be more restrictive. Patients on PD, they have to be less restrictive just because they do it every day. So sometimes they actually can develop so much potassium control that their potassium is low. So we have to kind of manage it. But most patients who are on hemo, they need to watch their diet. And the calcium and phosphorus, again, diet is the main. So imagine if of the phosphorus, so dialysis can only budge 20 to 30% of the phosphorus load. The binders, which actually patients take the pill with the food, so it binds to the phosphorus in the food, then patients poop that out. That is the other, maybe I would say 30-40%, but really the biggest help comes from watching phosphorus in the diet. So anytime the calcium and phosphorus is abnormal, this leads to high parathyroid hormone. I'm sure the PTH, most dialysis units, they check either every 3 months or every month. And the problem is once the PTH starts to go up, it sucks the calcium out of the bones and makes the bones weaker. So, and it also leads to more calcification just because you are really disturbing this calcium stores in the body. So body has kind of some calcium rocks. So this hormone is going and chipping the calcium away, and it's kind of now bringing it back in circulation. So that's where you see all these calcification problems. So again, management is restricted diet, and then, take the binder, and then take the supplements. So dialysis, also you can adjust the prescription, which is an important aspect. But if you want me to ask, the main thing is diet control and the binders. All righty. The other problem we discussed was the volume status, which is salt and water. So what happens if the salt level or sodium level is too high? What we have seen is the blood pressure is high. That's why I think, and then swelling is there. Patients can develop congestive heart failure. And then if the sodium level is kind of out of range, then they have muscle weakness. So if the patients who have been on hemo, if you have swelling, you know that your blood pressure always remain high. And that blood pressure responds much better to removal of the fluid rather than taking extra pills. So that's where I think salt and water control really is a helpful thing. So how can you manage salt and water problems? So again, I think unfortunately or fortunately, dietary restriction is where things start first. Like you, as Philip mentioned, try to prevent things in the first place. And I think with both dialysis, again, we chase the dry weights all the time, but if the fluid gain in between treatments is reasonable, it does not ask the machine to remove a lot of fluid per treatment, and it's not as stressful on the body. I think this is a message when you will teach other mentees, you should tell them that, hey, listen, the more the fluid gain is, the harder these machines have to work, and this is also bad on your body. So if you don't gain too much in the first place, then you don't have to remove that much to begin with. So this is an important message. The other components, I think we touched base about the vitamin D and erythropoietin. Erythropoietin is for anemia. So so that's where I think most patients, they get either active vitamin D supplements, the calcitriol, which Ashton mentioned, or Hectorol, or they get those anemia shots. I think we covered this slide. And how do you treat the kidney failure? This group already knows that hemodialysis, which is 3 to 4 times a week, 3 to 4 hours each time, more restrictive with fluid. You have to make travel arrangements. And then the biggest success is with the fistula. So you need to have this primary AV fistula. This is a circuit for dialysis, hemodialysis. Wow. Is this like a complex picture for you to understand, or this looks pretty simple? So if I simplify this, blood is taken out of the machine, go through these pumps, and really this goes through this dialyzer. The dialyzer is the filter, is the artificial kidney. So everything that happens is in this region, in the hemodialysis, and then blood through some pumps is pumped back into your body. So that's the simplistic version. Of course, it goes through a lot of those pumps and machines, and you can do different things. But the basic is kidneys filter the blood. This dialyzer, which is the artificial kidney, and you all know it's kind of this thing so this filters the blood. And this is how the dialysis looks inside. Inside the dialysis, these are hollow fibers or small pipes of these are very micro fibers. Blood goes through those hollow fibers, and then fluid goes around it. So there are 2 compartments inside that filter. This is a nice picture of AV fistula and AV graft. So really what they do is if you like surgeon connects basically your artery either naturally or through the synthetic pipe to the vein. If this is natural here, then the vein, it actually gets bigger and thicker. So the vein can be accessed. But if this is like this graft, I think it's kind of, again, it provides an area for a decent access to the blood flow. So this slide is about home hemodialysis. I'm sure all of you know about there's a different machine you can do dialysis yourself at home with the hemodialysis as well. So it's it's 4 or 5 times a week. It's shorter but higher number of treatments, and again it offers better control of blood pressure, anemia, and it's less restrictive. But then you have to do it, and it needs a decent access. Peritoneal dialysis, I think some of you either are on peritoneal dialysis or they have done in the past. So this is the belly dialysis, no blood is involved. 2 concepts. One is you use the machine, which you use the cycler, or you do it yourself, which is the manual. So the CAPD is the manual one. The CCPD is with the machine. This is the concept of the belly dialysis. So again, this is the catheter. Can you all see on my screen? I'm moving my mouse. So it sits on the belly. What you do is, in the simplistic way, is that this is the fluid bag. 2 liters of the fluid or 3 liters is actually instilled in the belly. It sits there for a few hours, anywhere between 2 to 6, and then you drain that. So the membrane actually creates this artificial urine. So the fluid has ability to suck some fluid out of the system because it has dextrose or glucose. But really, when all this thing sits in the belly, it causes that filtration using the belly membrane. And then usually what happens that they pour 2 liters in and 3 liters comes out, or 2.5 liters comes out. So this is the artificial urine, as I mentioned. This is the picture of the cycler belly dialysis. And again, this is just a scale and a warmer, and it's connected to some of the tubes. And it's very simple to do that. And this is the catheter that sits inside. So this is the outer skin. This is the anchor that skin sits in the skin. And then there is another anchor that goes inside the belly. So the catheter does not move. And then, it kind of circles inside the body, like right lower in your pelvis. Kidney transplantation, it says that this topic is a huge topic within itself. So this will be covered by the specialist. And I think I am at the end of my presentation. So let's open the house back up. Let me stop sharing, and so we can start seeing each other and open the house for questions.
No, I just had a question, because I feel like this is something that might come up for us as mentors. At what is the I used to know this, but I can't remember off the top of my head. At what GFR are you considered to be at end stage and needing dialysis to survive?
Yes. So if you look at the staging system, so GFR less than 15, that means this is stage 5 chronic kidney disease. So anybody who enters on paper GFR less than 15 may qualify for dialysis, but that should not be the sole kind of the indicator to determine for them to start on dialysis. You really combine the lower GFR with having some symptoms, so they actually get some benefit from doing dialysis. Because I have some of my patients who have GFR as low as 5 and 6, and they have 0 symptoms.
Wow.
And every 2 to 3 months I see them, they don't have any symptoms. They function, their mental function is intact. They go to their job every day. they manage themselves. They do great. They do exercise. So again, there is huge individual variation. So number is just a number. Please combine number with some symptoms. But when patient asks, so yes, less than 15 when you enter it that zone. Once you combine symptoms with the lower number, that's the time to consider dialysis. Now, one thing which is a good trick thing, which I will certainly like to mention, is that if somebody is having GFR going low, and then say this is 17, 18, or 19, I actually like them to see the transplant surgeons and transplant teams sooner, even when this is above 15, so they can be listed. And one of my patients recently got transplanted without starting dialysis because he got listed when the GFR was like 18, 19, and then, you know, as long as it's below 20, you can be on the list and you gain time. So this is an important conversation with pre-dialysis patient, is like, hey, listen, even if you're not on dialysis, if the GFR is less than 20, if you're a candidate, you should get listed. So even you're not doing any transplant today, but maybe you're gaining some time. If you get 1 or 2 years of time before starting dialysis, that goes into your bank account for the time. So you can actually use it, and this is very good thing. And I think as a nephrologist, we just need to be very, very careful. As if I see somebody's, you know, GFR is just drifting below 20, I just give them benefit of doubt, and I ask the transplant teams to see them. And I'm very lucky. Personally, I'm very successful that a lot of my patients got transplanted. A lot of my patients.
Okay.
Cool.
Thank you.
Any other questions? All righty. I think it looks like that Larry is next.
Oh, well, thank you so much for your time. Both Dr. Farooq and Dr. Carroll were very quick to say, yes, I'll teach that class, Lynn. So I really appreciate that. I appreciate your time and helping us out here at the Kidney Foundation.
Thank you, everyone.